written by an educational grant through OSU Medical Center Graduate Medical Education. A disclosure statement has been signed and is on file in the Graduate Medical Education Office. Dr. Fugate is a clinical professor of pediatrics and medical director of the Family Health and Nutrition Clinic at Oklahoma State University. She is a board-certified pediatrician and diplomat of the American Board of Obesity Medicine. Dr. Fugate works with multidisciplinary teams to provide obesity prevention and management services and educational curricula. Please welcome Dr. Colony Fugate.
Good morning, everyone. Welcome to Grand Rounds. I'm going to go ahead and get my presentation pulled up for you. And hope that you guys are able to see everything. You able to see it? Yep. Okay, good deal. All right, so we're going to get started. Today, I am going to talk about the Obesity Medicine Education Collaborative's core competencies in obesity medicine. And this work has been going on for quite some time. And whew, this little thing, this bar is driving me crazy. There we go. Has been going on for quite some time. Paused obviously during the pandemic, and some of that work has restarted. And so I was supposed to do this presentation about 2 years ago, and here we are. So I do have some disclosures. I am the primary site investigator for several clinical trials, none of which have to do with this presentation. I am the George Kaiser Family Foundation Endowed Chair of Pediatrics, and some of those funds are spent on obesity medicine education and obesity medicine outreach work. So, my hope for you is that by the end of this presentation, you will be familiar with the core competencies in obesity medicine. You'll be able to locate the resources, including myself, that you need to implement curricula in your programs or to guide your professional development, and to reach out if you need assistance with that. And so with that said, we'll go ahead and we'll start here. Our mission, when we were developing the core competencies and the evaluation benchmarks, was to, I have got to get rid of this little thing. There we go. Was really to be used in medical training programs. But these core competencies, as you'll see throughout this presentation, really can be used in a multitude of ways, and have been used in a multitude of ways throughout the training that we've been providing. There you go. So I think we're all very familiar as individuals who are part of academic medicine, either as a person who's in training or a person who is training others, of what a competency is. We know that in obesity medicine specifically, that historically providers from all different professions, medicine and other health professions, have had low knowledge and self-efficacy related to obesity prevention and intervention. And so it has been quite some time that the work has been done to improve self-efficacy in providers. We know that knowledge and self-efficacy can be a barrier to implementation of obesity care within a medical setting. So basically, this work started a long time ago, probably prior to 1985, but we know that in 1985, the National Academy of Science recommended that medical schools incorporate 25 to 30 hours of nutrition education in the preclinical year. So that if you're speaking about a medical school, that would be your first and second year traditionally. The Surgeon General's report by C. Everett Koop reiterated this in 1988, and the government awarded 21 nutrition academic awards to multiple institutions throughout the country. Those came in multiple cycles, starting in 1998 to 2003 and 2000 to 2005. And so many members of the medical community in multiple different fields began to work on developing nutrition education, curriculum, and disseminating that into medical schools. However, we know that it really didn't ever quite get implemented into medical training programs at the level in which is recommended through these various associations and government reports. In 2007, AAMC began to kind of move from a nutrition education specifically over to obesity medicine. That spurred many of the individuals who were part of the Nutrition Academic Award to move over into obesity specifically. And then the Bipartisan Policy Center and the Obesity Medicine Education Collaborative, of which I have been part of, worked in tandem to develop two different sets of competencies. The Bipartisan Policy Center is much broader beyond the field of medicine. The Obesity Medicine Education Collaborative core competencies were really developed to be used in medical training programs. That's not limited to MDs and DOs, but also includes PAs and NPs. However, in practice, these core competencies have been used more broadly. And so you can see that this was made up of a steering committee along with the remainder of the subcommittees that were the writing groups, of which I was part of the writing groups and have worked closely with the steering committee for a long time. Basically, what happened before the Obesity Medicine Education Collaborative is that each one of these professional societies were pretty much working in a siloed fashion. The collaborative brought all of these societies together with representatives from each one of these groups to participate on this committee. And my role was to both be a representative of the Obesity Medicine Association and the Obesity Society. So our work was done in phases. And again, it was kind of stopped 2 years ago and has since restarted. More in a siloed fashion than the collaboration at this point. But in phase one, we identified the domains and competencies and identified those benchmarks. Not completely done with phase one in that the next steps prior to pandemic were to develop those entrustable professional activities and then give some guidance with curricular content and design, because we know that not every institution has the resources or expertise to develop curriculum or the time to develop curriculum. And so it was the desire of the committee to actually develop those EPAs and the curriculum to assist if institutions desired that assistance. The competencies, once they were completed and those benchmarks, went out for external review and endorsement and dissemination. And this is part of that dissemination process. And so you can see that we developed the competencies with 6 domains and 32 competencies. And this should look very familiar to those of you who have worked in academic medicine, especially to our residents who get to see their evaluations and our program directors who work directly with the competencies. And so you can see that each of the domains should be fairly familiar, recognizable, as you may see them in your own specific practices, whether that's family medicine, internal medicine, OBGYN, pediatrics, and so on. So really looking at patient care and procedural skills, medical knowledge, practice-based learning and improvement, systems-based practice, professionalism, and communication. So again, these went out for external review after initial writing, and there were stakeholders from multiple professional societies that reviewed these core competencies and provided feedback to the core committee. After receiving feedback from various professional organizations, we went back and revise the core competencies and the benchmarks accordingly. And then they were finalized. Once they were finalized, they went out for endorsement to many different professional societies, and you can see some of those here. Along with endorsement came the process of dissemination. And so again, dissemination was where we were pre-pandemic, right at the beginning of the pandemic. And so it kind of got cut short a bit, and again, kind of beginning that up again, along with beginning those EPAs and beginning that curricular development again. And so we have had publications throughout the process come out of the committee, reached out to multiple professional societies, presented at multiple professional societies, including ACOM and the Society for Teachers and Family Medicine and others. And so those presentations and publications are out there, and I've included some of those publications at the end of this talk in my references, as well as some resources where you can find more information about the work that we've done. So these were, again, they were originally developed to be used and implemented within medical training programs. Again, not specific to DOs and MDs, but the broader provider design. They have been utilized, though, as we moved into the dissemination phase much more broadly to help the provider in practice to develop their own skills and design their own training should they desire to improve their knowledge, skills, self-efficacy within the realm of obesity medicine. They have been used to guide item writing for various boards. In fact, that was one of the processes that occurred in the very early stages of this, was that we had multiple committee members sit down and look at the USMLE and go through the entire question bank and look to see what questions were related both directly and indirectly to obesity medicine, and to then provide feedback and recommendations to the USMLE regarding obesity medicine content specifically. And then many of the committee members have gone on to be item writers in really in, again, driving forward obesity medicine and originally nutrition education within medical fields. We have used it to guide both preclinical and clinical training. We've also used it out into the practice setting, guiding things like our ECHO, which is more didactic, but also staff training, professional training that may occur, for example, in this setting. Also for public health providers, we've provided workshops and training for public health providers to, again, improve their knowledge, skills, self-efficacy regarding obesity itself and obesity medicine, so that public health campaigns, public health messaging are more consistent with evidence-based practices. So these are free, these are open source, they are housed on the Obesity Medicine Association website, and I have that link right here in the slide, but also in the resources at the end and the references at the end as well. So you have access to the entire set of the 6 domains and 32 competencies with all of the benchmarks. Included in this is not just the competencies themselves, but an instructor guide. And really this instructor guide is to help you with implementation from curriculum specifically to guide learner assessment and to help with all sorts of other things, including the assessment of existing curricula, assessment of planned curricula, and again, for item writing and other things that you may be working in. As well, it's also meant to help with, MOC, professional training, and long-term continuous education as well. And so again, these instructions are part of that toolbox and part of that competency that you can find at the OMA's website. And so again, we have those competencies, that observable ability of a health professional related to a specific activity that integrates knowledge, skills, values, and attitudes. And then we have those benchmarks. Again, most of you be familiar with this. And those benchmarks really allow us to evaluate the learner for any given competency and a learner at any given level. And we know that when you're talking about competencies and benchmarks, it's not like in the old days, right? It's not 5 is good, 1 is bad. That's not really how these work, and that's not how all of our medical education competencies work. These are meant to work the same way, that we are starting off as an early learner at a 1, and we're progressing as a more advanced later learner through the various stages of competency. Some learners, depending on where they are in their training, depending on their role within the medical profession and within the community working in obesity, may need to achieve further along that competency continuum, and others may not to have to. And so again, it just depends. And I'm going to go through some examples. And so whenever we're looking at these competencies, the very first thing we need to do is determine who our learner is. You know, not all competencies are relevant to all learners. And so the toolkit, again, is meant to be really flexible so that each organization can pick and choose domains and competencies and set their own benchmarks really based on their own needs and also their own resources. And so you can see in this example, we have the domain as the interpersonal and communication skills, and we have the competency as uses appropriate language and verbal, nonverbal, and written communication that is non-biased, non-judgmental, respectful, empathetic, when communicating with patients with obesity. And this is really probably one of the most important competencies that we have in obesity medicine, is to consider weight bias and respect whenever you're working with an individual with excess weight. So if we consider that early learner, so maybe that learner in medical school or early in their residency training. So when you're talking about interpersonal and communication skills, this competency might not apply to your first or second year medical student in preclinical training. It may be harder actually to evaluate. It may, depending on your program, as some programs like ours have specific curricula that's designed to improve interpersonal communication. And they have the ability to do some role play and to assess that in a clinical capacity in a very structured way in the preclinical years. This may be something that a program chooses to implement, but it may not be right for certain institutions. And so again, it just kind of depends on the institution. And so if we're looking at this one and we're thinking of an early learner and we're thinking about interpersonal and communication skills, it might be that we want to look at this competency of using appropriate language and verbal and nonverbal and written communication in the 3rd and the 4th year of medical school, and maybe if they're an early learner, a PGY1. And so we have these different benchmarks that we can use. Again, this should look fairly familiar to you, as this is how the majority of competencies and benchmarks that we use for assessment of residents are written. We have a variety of ways that we can do that. You can see the top line kind of gives us a more nuanced option, or the bottom line is the standard 1 through 5. And so with the early learner, oh, I lost my things. Oh no. Okay. So with the early learner, I'm going to use this over here. We might not believe that the early learner can consistently and effortlessly utilize appropriate verbal and nonverbal communication that is clear, concise, tailored to the individual circumstances when engaging with patients with obesity in all situations. And so we really might not be wanting a 9 or a 5 for our MS3, MS4. We might, though, once they've had some additional training and some time, really expect them to utilize verbal, nonverbal, and written communication that is appropriate when engaging with patients with obesity. So again, identifying who your learner is the most important first step. Are they an early learner or a more advanced learner? Because then we can set our benchmark. And so our desire for the program may be for our early learner, that MS3, MS4, for them to maybe reach a stage 2 and then maybe that PGY1 reaches stage 3. And so again, it's up to the program. These were designed to be flexible for the program to decide, again, which competencies, which domains, and how to set their own benchmarks. So then there is the consideration of the more advanced learner. And so when we're thinking of the more advanced learner, then let's consider medical knowledge as our domain. And so the competency under that medical knowledge would be to apply the knowledge of the pharmacological treatments of obesity as part of a comprehensive personalized obesity management plan. And so you can see that we have here, if we have the most advanced, then we have exceptional knowledge of age-appropriate pharmacotherapy options for the treatment of obesity, including their indications, contraindications, side effects, mechanism of action, and they can apply that knowledge to the clinical care of complex patients. And so for an advanced learner, we might expect that a fellow in GI, endocrinology, and obesity medicine would all be able to reach this level 5 or level 9, depending on which scale that you're using. We would certainly expect, if we were utilizing this for providers in practice, for continuing medical education, that a pharmacist who is evaluating medications for use on formulary for Medicaid, for example, that they would also have an advanced understanding and really reach the competency of either a 9 or a 5, depending on which scale. And so in order to make decisions that can broadly affect access to care, right? So we may not need this particular level of advancement. It may be that for the advanced primary care provider in practice, we really want to have an above average knowledge of age-appropriate pharmacotherapy options for the treatment of obesity, and that we save the most challenging patients for that specialist in that practice. And so again, it's completely up to the program, to the individual, on how they set their benchmark and which competencies to use. So then we can have that mid-level trainee, right? Somebody who is not an early learner, is not the fellow, but maybe somebody who is in their second or third year of a primary care specialty. We can pick a domain, patient care and procedural skills, and a competency utilizes evidence-based models of health behavior change to assess patients' readiness to change in order to effectively counsel patients for weight management. And so again, using that primary care resident who is in their PGY2 or PGY3 year, we might consider, how do we apply this particular competency to their training and assessment? We certainly expect a physician who's primary care to really be able to consider all of the pillars of obesity medicine: nutrition, physical activity, and behavioral change and behavioral counseling, right? We want them to be able to utilize evidence-based models of health behavior change, and such as our trans-theoretical model, our stages of change, utilizing our motivational interviewing, utilizing our cognitive behavioral therapy, utilizing things like the 5 A's, and setting SMART goals that are patient and family centered with our patients, right? We would expect that in most cases when working with individuals with excess weight. And so really that's probably going to put us at a level 4. For some residents, we know that in our benchmarks that we use for our primary professions, that a level 4 is perfect, exactly where they need to be to go out into practice. And for this one, for our primary care providers, this is likely what the benchmark you would choose is at level 4. Some residents are going to go well beyond, and they're going to reach this level 5. But some residents would go out into practice and really would take on most patients who have excess weight, but save those who are the most complex, have the most complex cases. Maybe they have significant and profound trauma that they're working through. And so therefore the pillars of obesity medicine, especially that health behavior change, are more challenging. They may save that for the specialist. Now, of course, with the obesity medicine specialists, we're going to expect them to achieve a level 5 in here. But for a primary care advanced learner, we're going to have them try to meet that benchmark of a level 4 by the time that they graduate. So again, there's a process to implementing these. Basically, the first thing is determine your audience. Who is your learner? Is it an NP, a PA, a DO, MD? Is it a student, a resident, a fellow? Is it somebody in practice? Again, are they an early learner or a more advanced learner? We're going to choose a domain. We're going to choose a competency. And based on our learner, then we're going to set our benchmark. We can use these competencies both in preclinical training and in clinical training, and again through continuous learning throughout. They can be used in medical schools and medical training, and again they can be used more broadly in other health training programs, even though initially they were really designed by a multidisciplinary team to be used in medical training specifically to help meet those contact hours that we're wanting in those preclinical years. And so again, in the preclinical years, institutions have implemented these competencies in a variety of ways. They have included them in specific focus courses. That's really challenging for most institutions, given that there are competing interests and we have boards that we're teaching to often. Many have integrated them both in the basic sciences such as biochemistry and pharmacology, or if they have more systems-based approach into those systems, including reproductive, endocrine, GI, cardiology, and so on. In the clinical years, we really, again, we may have the full spectrum of the learner. We may have our MS3 through PGY1, who's more of an early learner, and then we may have all the way up into our fellowship with the most advanced learners. And so, again, these really are designed to be flexible and used all the way throughout, including with MOC and CME and everything that we do in our curriculum with obesity medicine at OSU really is mapped to these competencies and guided by these competencies. And they really are flexible enough. I think as we moved to dissemination, we realized exactly how flexible they were and worked again with multiple groups in workshops to begin to implement these competencies within a variety of settings, including, again, out in practice and non-physician and non-primary care provider settings. So beyond the competencies and the benchmarks, we are beginning to come back together, develop those EPAs, develop example curriculums for those institutions that may not have the time or the resources to develop curriculum. And so you can see here that if we choose this competency systems-based practice, in the domain of systems-based practice, the competency works collaboratively within an interdisciplinary team dedicated to obesity prevention and treatment strategies. And so you can see here on the right, or at least my right, that we have these particular EPAs that we utilize in our pediatric obesity medicine clerkship. That particular clerkship is quite comprehensive. It's quite flexible. It was developed with a grant a very long time ago. I've been doing this for a while, I guess maybe 10 years ago. And it was developed by a multidisciplinary team in order to actually meet the curricular regulations of multiple different fields of medicine, including nutrition, psychology, health education and medicine. And it's been such a flexible curriculum that it's actually been able to incorporate family and social scientists and others into this clerkship. And so the clerkship varies. We may have somebody come for a week. We may have somebody who comes to us for an entire semester, and we have had both. And so there's a basic core curriculum, but then each one of these fields of medicine and public health actually have their own specific curriculum as well. And so you can see some of these entrustable professional activities that are really working towards this very specific competency within systems-based practice of working within interdisciplinary teams. First off, the students who may be on rotation or trainees who may be on rotation with other trainees from other disciplines. They're going to work with pharmacologists and dietitians and social workers and psychologists in addition to physicians when they're on this rotation. So they're going to have both that experiential learning in systems-based practice and interdisciplinary teams. They're going to have didactics within an interdisciplinary framework. When they have self-directed learning, those readings and modules, those modules are put together by a multidisciplinary team, and our residents and students from various fields are also sent out into the community to participate in policy and advocacy level, systems level work as well. And so you can see we can develop pretty robust and trustable professional activities and really robustly evaluate the learner in order to advance them on this competency within this one clerkship. So entrustable professional activities that would be associated with this particular domain: medical knowledge, applies knowledge of using behavioral interventions to develop a comprehensive, personalized obesity management care plan. And so these entrustable professional activities are related to continuing medical education specifically. This is some of the activities that we use in our pediatric obesity medicine ECHO. And so we have case-based learning, where this week we actually had a didactic on motivational interviewing. We had a role play that always seems to be really valued part of our curriculum each year, is to practice motivational interviewing for our providers in practice. We have self-directed learning, which we keep readings in our box, so to speak, for our ECHO, which are open source and available to anyone. We have experiential learning through the basis of case-based learning, where all members learn and all members share in their experience. And so you can see how these competencies are not just hyper-focused on residency training and medical education prior to GME. They really can be utilized very broadly. I have presented a workshop with my colleague, Nick Pennings, who is on the first slide. His contact information is there. He's at Campbell University. We presented at a workshop in Oklahoma City just prior to the pandemic for public health professionals, and helping them walk through these steps of how to implement the competencies within their own system in order to advance public health around obesity. And so again, we start with our learner. Who is our learner? Are they an early learner? Are they advanced learner? Are they studying to become a physician, or are they working in a different health profession? And we want to know our short and long-term goals by utilizing and implementing these competencies. We need to know what our resources are. Do we have the support to implement these competencies, and what resources do we need if we don't have them? And then from there, we can develop those entrustable professional activities based on our learner, where and how we want them to advance, and we can create curricular content. And how we've done this in our workshops, and how I recommend that you do it, is through the logic model process. It really is a process. It's very dynamic. It's very group oriented. In a residency program, probably it's optimal to include your program directors, representation from each one of the years of residence, if you have a fellow as well, including your fellow, and really kind of figuring out what your goal is. what's our goal first, both our short and long-term goal, and then work backwards on your logic model. What inputs do you already have? What resources are already there? What do you need? What is not available at this time? What is available, maybe not within your own institution, but is open source and widely available? And then you can plan your activities and work towards the outputs from a curricular standpoint. And I really recommend that you do this with either multiple domains or multiple competencies within the domains. And I've done this with multiple groups, and I'm certainly here to help you. And again, there are other members of the OMET committee who are still working in this area. We've begun to reconvene more in our siloed agencies at this point to begin this process and move it forward from where we left off 2 years ago. And so we're here to help you with this process. And so please, if you want to utilize these, again, they're open source. They are available to you completely free. There are tips on how to implement these. Again, there's an instructional guide. You can go to any one of these websites for additional information and for professionals to contact to assist you. I want to acknowledge that I did not put this entire slide deck together alone. This is something that came mostly from OMEC and from the committee, and that Dr. Pennings and I worked together to put together for the various workshops that we have provided. And here are my references. And again, there are links to the competencies so that you can have the whole set, and some of the literature that has been published out of the group. And so with that, again, my email is here if you have any questions and you want assistance with implementing the competencies, you want assistance with developing EBAs or curriculum. We've got a ton of it and more is to come. The Nick Pennings is also on here. Again, he's over at Campbell and he is with the Obesity Medicine Association. OMA has curriculum on their website that is available for fee and also is working to update and develop curricula that can be disseminated more broadly based on these competencies, again, restarting that work. And so with that, I'm going to stop sharing my screen. I will take any questions if anybody has them. I have explained the competencies so well that no one has any questions. Okay.
Thank you, Dr.
Well,
Fugate.
thank you guys. I appreciate it. And again, if you need anything, let me know. I'm happy to help. I don't want you to have to reinvent the wheel for your continuing education or for your program. There's a lot of curriculum already out there, both at our institution and nationally. And I encourage you to take advantage of those inputs so that you don't have to do that yourselves. So thank you very much for your time.
Thank you, Dr. Fugate.
You're welcome.